Greetings to you all. I'm Nidanda. So, our study titled as Optimizing Leptospirosis Diagnosis in Sri Lanka, selection of regional serovar panel for cost-effective medical implementation. Simply, I'm going to discuss a possible solution to improve the diagnostic coverage of leptospirosis in Sri Lanka. So, these are the contents of my slides and let's move to the background. Leptospirosis is a zoonotic disease caused by the spirochete bacterium called Leptospira, and the main reservoir cause can be include pigs, rodents, cattle, mice, etc. And the transmission can be by direct transmission and indirect transmission. We can consider direct contamination with infected animals' blood or urine as a direct transmission, and environmental factors such as water, soil contamination with infected animal urine as indirect transmission. So, microscopic aggregation test MAT is a recommended diagnostic test for the leptospirosis. Principles simply based on the aggregation reaction between live leptospira antigens and patient serum antibodies. But this MAT is restricted to few laboratories due to challenges. It's a very complex procedure and high cost to maintain of live leptospirosis serovars and need a highly skilled technical staff and as well as lack of regional specific methods. So considering these factors, leptospirosis remaining underdiagnosed in Sri Lanka despite its endemicity in the country. So our research hypothesis was use of regional specific methods with few serovars is a feasible approach to improve the diagnostic coverage. Based on that, we found a research that there are data evidence for seroreactivity in clinically suspected patients remaining extremely limited. So based on that, we defined our objective to identify the most prominent reactive leptospirosis serovars in clinically suspected patients in North Central province, supporting the development of regionally specific limited serovar panels. So when we moved to methods, we received 329 serum samples from 4 main government hospitals in North Central province to the Public Health Research Laboratory, Department of Medicine, Radha University of Sri Lanka, and we performed MAT by using the 11 serovar optimized MAT panel. So let's see about the optimized 11 serovar MAT panel. It's based on the identified study, and there are 11 serovars representing 10 serogroups and representing 3 pathogenic species and 1 saprotic species. So let's go to MAT interpretation. Simply MAT reactivity we can define is a 50% or more than 50% administration reduction compared to control. Here you can see the control image under dark field microscopy, high power field. So if we assume this is 100% of live leptospirosis serovars, the second one you can see there, if there is 100% live leptospirosis serovars, if reduce that 100% to 50% or more than 50%, we can take that as a reactive leptospirosis case. So the second image actually is a more than 50% administration reduction. Even it's 50% we can consider as a reactive, but when we are moving to the MAT positivity, it's slightly different from the MAT reactivity. So currently we are adhering to the WHO LERT criteria. So it says the sample showed titer 1 in 400 or more than 1 in 400 in acute for paired samples or 4-fold rise in titer. So simply, if we dilute our serum 400 times and compare with the control, if it is still showing 50% reduction, we can take it as a MAT positive case. So when we move to the results, out of 329 samples, 71 got positive for the MAT, and out of 71, 58 show positive via acute paired sample only from one sample, and 13 got positive via paired sera with the convalescent sample. So out of 71, 18 only reacted to the single serovar, and 53 show 2 or more serovar reactivity, multiple serovar reactivity. So let's move to the titer-based comparison of MAT positive cases. Out of 71, 28 samples got reactivity 1 in 3,200 or more than 1 in 3,200 titers, and 22 samples got positivity in 1,600 titers, and 12 in 800 titers, and 9 in 400 titers. So let's move to the serovar-based comparison of MAT positive cases. All the 11 serovars that we used in this study show me variability of seropositivity. Leptospirosis improvement serovar ectoimmunology was the most frequent reacted serovar, reacted with 54 samples, actually positive with 54 samples, and notepad is a special in Bratislava. It's not the most frequent reactor, but Bratislava was the most predominant zero to yield the highest yield. It yield 1 in 3,200 and more than 3,200 liters in 18 patients. So the overall, I'm going to tell out of 71, 64 samples, it's 9.1% samples show zero possibility at least one of these four predominant zeros, at least one of these ectodermatology, canicola, Bratislava, pattern. So 64 samples reactive, at least one of these zeros. Only 7 samples got positive without this one of zeros. So based on that, we are concluding that this study demonstrates 4 predominant leptospirosis zeros account for 90.10 positivity with the clinically suspected sample from North Central Province, and these findings about the use of regionally specific map panel with few zeros as a feasible approach to improve the diagnostic coverage. Not that as well as it's a clinical benefit as well as research, or when we consider about the research also, it's more benefit because if we can do like these studies for each and every provinces or district based, we can find the most predominant zeros, and we can if we can implement few zero panels, definitely it will upgrade the diagnostic coverage as well as research studies as well, because research also currently doing very few stations in Sri Lanka about the leptospirosis. So these are the main conclusions of my study, and these are the references that I have used for create these slides, and acknowledgement with the patients and bystanders who came to the laboratory and gave their samples, as well as my supervisors and our medical laboratory science graduate team. Thank you very much for listening.
Great, thank you.